基金會2013醫學研討會第2部分現在開始。首先介紹一下我哋嘅主持人，分別有香港中文大學內科及藥物治療學系何鴻燊呼吸系統學講座教授及何鴻燊防治傳染病研究中心主任許樹昌教授，以及係實踐大學董事長謝孟雄教授。另外，第2部分為我哋主講嘅嘉賓，我喺度都同大家介紹一下，佢哋分別咧就係香港中文大學眼科及視覺科學學系名譽臨床副教授劉大立副教授，台灣長庚大學醫學院婦產學科李其龍教授，香港中文大學婦產科學系教授盧子希教授嘅。呢個時候咧，我哋將時間交俾主持人啦。
歡迎各位，好高興可以同阿謝孟雄教授主持第2節嘅研討會。第一位講者咧係劉大立醫生，咁劉醫生咧係香港少數嘅玻璃體視網膜領域嘅專家，佢咧就係專攻係視網膜同埋葡萄膜炎嘅，咁發表過好多相關嘅文章，亦都係攞過好多眼科嘅獎項嘅。咁今日劉醫生呢個題目咧就係老年黃斑病變及白內障嘅最新節目。劉醫生，唔該。
Chairman, colleagues and friends, ladies and gentlemen, good afternoon. I would like to take this opportunity to say thank you to the organizing committee for inviting me to be here to give a talk. And it's really my pleasure and honor. I have no relevant financial interest or relationship to disclose. So my topic today will be two things. One is the age-related macular degeneration, AMD, and second one will be cataract. So I'll talk about AMD first. So why AMD? Just give you a little figures to give you how bad this problem is. Right now in the developed countries, including Hong Kong, of course, and Macau, the #1 cause of irreversible vision loss in the elderly is AMD. And in the US alone, the advanced AMD patients amount to the figures of 1.75 million right now. And only 8 years down the road, which is 2020, the figure will double itself to 3 million. And by that year, the whole world will see a staggering 80 million people suffer from AMD. So this is really a global problem. But in order for you to have a better ideas of, I know not every one of you is a ophthalmologist, so it's a good time for me to give you a little bit orientation of the eye. All right. For the eyeball, everyone know what eyeball is. Eyeball function, everyone knows, is just like a camera, like a video to capture the image. But structurally, the eyeball could be reduced to 3 layers. Very simple, remember 3 layers. The innermost is the retina, followed by the choroid, and the outermost is the sclera. So, in other words, retina and the sclera will sandwich the choroid. So for the disease I'm going to talk about, just remember retina and choroid. Okay? So this is the picture of the normal retina. Okay, we can see the above is the retina, and here is the choroid, and this is divided by a layer of cell called B cells. All right. So for AMD, the problem is you got some new vessels spreading from the choroid into the retina. All right, breaking the barrier in between, including the Brooks membrane. So if the problem is really bad, you get pretty bad hemorrhage there, and then you end up with a big scar like this. This is the macula. So we totally destroy the central vision. All right, this is typically what patient will tell us if we are suspecting a patient having a AMD. He or she may tell you that she suffered from a very bad central scotoma, disruption of the image, the Schönke metamorphosis, or some visual field defects around the central or the pericentral region. So pathologically, if you take a lot of people will develop AMD, it's mainly because at the choroidal layer, you get some relative ischemia and hypoxia. And this hypoxic drive will then leading to the spurting of the vessels from choroid through the closed membrane into either the RPE or the retinal layer. Okay, a very common figure is illustrating to you how the disease might develop. So not for CMV, the cause could be AMD, but apart from AMD, we've got myopia, you got inflammation that could also give you a choroidal neovascularization. All right, as for the visual loss, we know AMD is the major cause of blindness in the Western world, and about 80 to 90% of the disease or the loss of vision is due to the CMV formation, choroidal neovascularization. As for the rest, it's either atrophy or a serious retinal detachment. So, if you cannot remember anything about AMD, just remember this slide. Okay, for AMD, got two types. One is dry, one is wet. Dry is good, wet is bad. Okay, it's very simple. So for dry, what do we mean? We mean there's some abnormal deposition at the macular area shown here, the yellow deposition. Normally we will not see something like this. But if the problem is really bad, the dry could progress to wet and causing hemorrhagic changes as shown here. There's a hemorrhage. Okay, what about the factors? What factors will contribute to AMD? As the name implies, is age-related. So age is the number one cause for AMD formation. This will be followed by smoking, hypertension, cardiovascular disease, and possibly some nutritional factors. But we know from the studies the confirmed factors are age or smoking. So this is a very simple diagram illustrating to you once again. For the development of AMD is proportional to your age. The older you are, the higher risk for you to develop AMD. Genetic factors do play a role. I will come back to this in a minute. So as for prevention of AMD, how to prevent AMD? Just like Chinese, we have the inclination to prevent something, all right, by taking something. All right, can we do so? And we got a clue from this study. We know that somehow the light rate would generate some free radical production, and this free radical could damage the photoreceptor RP layer and then contribute to the development of AMD. So could we block this formation of free radical? Okay, yes, the answer is from the big area study in America in 1,000 patients conducted over a period of 10 years, we now know that for AMD, especially the special type of AMD, you can prescribe the patient with antioxidants or vitamins, like shown here. And I was reminded by Chairman Prof. This lecture we conducted as a bilingual. All right, so this is important point. So I'm going to repeat what I'm going to say in Cantonese. 其實咧就可以食維他命嘅，咁但係咧就即係有好多坊間好多誤解咧，就以為咧就即係食啲譬如話有啲咩藍莓啊嗰啲咧就有用嘅，因為我係每一日咧都俾無數個病人問我咧藍莓有冇用嘅，咁我諗各位都可能會有個疑問，即係究竟藍莓有冇用咧？咁其實呢個答案就係咧，藍莓係完全冇用嘅。好吧？咁你會問喂藍莓咁貴，點解佢完全冇用咧？咁我標準答案就係藍莓貴咧，唔係因為佢有用，係因為咧藍莓個廣告裏邊咧任達華收片酬係高嘅。Okay, so remember you got free vitamins, alright? They are proven to be useful, but not over. Okay, from recent study we know that we got another magic bullet. It's very promising. We call it the CNTF, the cerebral neutral factors. 節狀體神經生長細胞，神經生長因子 is a new drug that could possibly reverse some very bad atrophic changes of the AMD. Or previously we can do nothing about this condition. But right now, if you give one injection, probably you can reverse the vision of the patient. Alright, we have talked so much about the dry AMD treatment. But what about the treatment of wet AMD? For AMD treatment, wet AMD treatment, my only feeling is very difficult. Alright, very difficult. Because the pathogenesis of this disease is so complicated. All right, people have to think about a lot of treatment modalities to tackle this problem. As listed here, I will walk through you one by one. All right, surgically, all right, Chinese always favor surgery. All right, so my patient asked me, Dr. Kane, I fix this problem by surgery. But very unfortunately, the answer is no. Why? Because for surgery, you've got to perform surgery beneath the retina. That means this is subretinal surgical removal, which is a very tedious and technically demanding procedure. And post-op, the outcome is pretty unpredictable. So as the macular translocation. The idea of this surgery is just to rotate the retina, rotate the bad part away, and then the good part coming into the most important area. Once again, the risk is so high, and then the outcome is pretty unpredictable. So no one will perform surgery for the AMD patients. What about ionizing radiation? Once again, the effect is pretty unpredictable and unproven. PTT is still under study. It's the infrared light photocoagulation to burn the abnormal vessels. About 15 years ago, people had thought about the use of a direct focal laser, 二能激光, to burn the abnormal vessels. But once again, as shown here, if you burn the vessels, you also burn the important part. So you give the patient, you can kill the vessel, but you leave the patient with a big scotoma. So no one will use this anymore. So nowadays we have got a pretty new treatment. It's not new anymore, actually. It's about 10-year history. It's called photodynamic therapy, 光動力療法. This is a new laser, it's a cool laser. It's different from the thermal laser, which is a hot laser. For this one, what you need to do, you just to infuse the patient with some photosensitizer. And then you will, with a certain period of time, you irradiate the disease area with an infrared laser, and this will activate the photosensitizer and produce a thrombosis, a vascular occlusion defect. And this is a very busy slide showing you how we decide what kind of treatment should be treated by the PDT. But we are living in the era of anti-VEGF right now. Anti-VEGF is a pretty new treatment. It's only for 5-year history. What we need to do, we just use a needle to inject the drug into the eye directly to tackle the AMD problem. And this is the caption of what we normally do in our clinic. The office, this is office, which is this is patient lying there, and then we'll give the injection. So 2 drugs right now is popular in the market called Lucentis or Avastin, 落明症, Naxitin. I'm sure you have heard about this. It's pretty hot previously in the news. There was a debate. So this is the schematic drawing history to you how the anti-VEGF could work in the treatment of CMV. Just give you a little bit of orientation. This bit is the retinal pigment epithelium. This is the Brooks membrane, and this is the choroid. Remember, this is the retina. Here is the choroid. All right. So for the formation of CMV, you've got to have some formation of vascular endothelial growth factor, 血管內皮生長因子. And this is pumping out from the retinal pigment epithelium, and then reach the choroid, activate the formation of CMV. So the principle of anti-VEGF is to block this and then preventing the formation of CMV. In 2006, you got 2 very important keynote papers published in New England Journal of Medicine. One is a Marina, one is Anchor. This study is the first time in human history proven that anti-VEGF could somehow improve the vision in AMD patients. In the past, if you use PDT, at most the vision could be stabilized, but could not improve. And if you use anti-VEGF, for certain amount of patients, the vision could be bring back or even improve. So Lucentis is the magic bullet for AMD. But the trouble with Lucentis is that Lucentis is really expensive, really expensive. So I'm not sure you have got any ideas or not. Maybe you can do a little survey to see whether you know the answer or not. Any other thing, Lucentis just 5,000, 10,000, or 20,000.
US dollars, Hong Kong dollar.
No. Hong Kong dollars. Hong dollars. Any idea? 20,000. 20,000. We got only 10,000. What about the rest? Okay, it's pretty close. It's 10,000 actually. It's not that much. But what about Avastin? Any ideas? How much is Avastin? One shot.
10 times.
Avastin? No, it's 10 times less or 10 times more. Any idea?
Less.
Yeah, Avastin is much cheaper. It's just like maybe 300 per shot against 10,000. All right, think about that. It's pretty. The difference is quite significant. It's because of the big difference. So some genius in the States, couple of years ago, have used Avastin to replace Lucentis and off-labeling, because for Avastin previously it was used as a anti-cancer drug, or for the chemo. It's primarily into the bloodstream and intravenous. But right now, some genius borrow this drug and then aspirate certain amount and inject into the eye, and found that the effect is very comparable with Lucentis. So, an avoidable question you've got to ask by you or the patients, is Avastin similar as Lucentis? Now we know the answer is pretty much the same. From the big study, like CAT study, it's a big study published in the last year. It's proven that Avastin shared the similar efficacy with Lucentis. But people have doubted that Avastin might be relatively contraindicated in the individual with history of certain cerebrovascular or cardiovascular diseases. Okay, some new drugs or new bullet called evitasep. This is called the VEGF trap. Or this is a primary chimeric protein, and it could bind directly to the VEGF, of a much stronger potency and affinity. So theoretically, this drug is much better than anti-VEGF in terms you don't need to inject so frequently. All right, and remember I talked about the ionizing radiation, right? And the problem with ionizing radiation externally is because you irradiate the eye ocular surface as well as the retina, and give you a problem of give patients some problem like dry eye or neurosensation of the ocular surface. But once again, the American doctors, they thought about the use of, we call it the epimacular brachytherapy. It's some radioisotope is implanted at the tip of this instrument, and then through the surgical procedure, we just bring this very close to the macula and irradiate the abnormal vessels, leading to a regression of the vessels. So this is one of the very promising treatment right now, and the Kevin study is actually investigating the efficacy of this treatment modality. So from the genetic study, we know that AMD possibly is very complicated, but two pathways are very important. Number one is the lipid metabolism dysregulation, and the second with the innate immune system dysregulation. Okay, this is a really complicated slide. It's showing to you how the genetic factor could possibly contribute to the formation of AMD. We see the here immune dysregulation is regulated by some. This is well accepted polymorphism of AMD is the CFH complement factor H, or CFB, or C2C3, and certain polymorphism related to the lipid metabolism has also been implicated as possibly related to the formation of AMD. So through this, now we know possibly in the future we can use some gene therapy to target against this known polymorphism, and this could possibly reverse the AMD problem. So gene apart from the gene therapy, we know that gene could modulate the treatment response by titrating the effect of anti-VEGF, PDT, or even some vitamin antioxidant effects. Proteomics is a new field. We know that if you can identify some certain protein fragments within the bloodstream, so somehow maybe you can pre-screen the patient and then give the patient an idea the likelihood of patient to develop AMD, say, in 5 years or 10 years, before the appearance of certain characteristic phenotype. So, AMD is a leading cause of universal blindness in developed countries, and some special complaint like distorted central vision is really alarming and should necessitate a prompt referral to the ophthalmologist for a proper assessment. And the new treatment like anti-VEGF or VEGF trap, they are very promising. But you've got to make an early diagnosis and offer the patient a chance to receive treatment as early as possible in order to salvage the vision. Okay, we have finished the AMD, all right, and then we quickly move on to cataract. Cataract is something at the front. I'm sure everyone have heard about the term cataract biology. What this means is due to opacification of lens. This is the textbook definition. As shown here, all right. This is cataract. So cataract, you can classify by severity, by location, by causes. Okay. Which one is more severe? This one, or the first? Any idea? Any idea? Any ticker? The first? The first? The first? The first, okay. You could be an ophthalmologist. Yeah, okay, correct diagnosis. All right, causes of cataract, okay, it could be either congenital, traumatic, okay, due to advanced age, drug-induced or diabetics. Okay, sadly, kids could get cataract. That's shown here, this is congenital cataract. And then sometimes for very bad diabetics with neovascularization, as shown here, we got very angry-looking vessels at the iris, could give the patient a very bad cataract because secondary cataract. So it's right now cataract is a major problem in Hong Kong because of aging. You got growing population, longevity, and aging population. So it's the commonest eye problem in the elderly. But luckily, this is reversible. This is reversible. I'll talk about this in a minute. So symptoms, all right. Symptoms for cataract patient, normal should be like this. Cataract patient will see something like this. Very, very, and then not clear with a decreased color, saturation, and shown here. Here is due to the cataract. You shuffle the light and then give the patient a very, very, unusual, unnatural perception of light. This is interesting. I'm sure some of you might experience this. All right, it's called the second sight. What does it mean? If you don't have cataract, okay, you need a previous of a piece biopic lens to do some near reading or work your iPad. But if you suffer from cataract, so this I'm not sure it's called bonus or not. This somehow you don't need this piece biopic lens anymore. You can see quite clearly at near vision. It's because cataract could confirm that the patient certain myopia, and this myopia could compensate with this myopia problem. We call it second sight. Okay, we'll talk about this. What about treatment? Now we know not every cataract patient should have got surgery. All right, so you could either observe what about medication, what about laser, what about operation. All right, observation will only be offered to those with mild symptoms only. What do you mean by mild symptoms? That means it does not affect the daily activity or daily living. Okay, if you have got a chance to encounter anyone talking about the use of medication to treat cataract, just forget about it. And please never see this doctor because he or she knows nothing about cataract. You cannot fix cataract with any kind of no medication. There's no way to do it. Or what about laser? The answer is yes, no. It's because in the recent 1 year, we got some new form of laser treatment for cataract. I'll talk about this later on. Operation, all right? In the past, there's a myth that only when mature, only when the cataract is mature, then you will need a cataract operation. So how many of you still a believer of this sentence? No one. Okay, you're good. You're very smart, all right? So right now, you don't need the cataract to be mature. You just judge based on the inference over the daily activities of patient. All right. If they've got impairment, it's a good time to a cataract operation. All right. Just a little bit history. 6th century, some Indian genius thought about a very crude way to deal with cataract. We call it 構情金針撥障. Or 金針撥障. What does it mean? You just use a needle to pierce the eye and then push the lens back into the vitreous. And this will leave the patient aphakic. All right, you solve the problem. Patient aphakic can count finger, and patient will be very happy, but only happy for a week, because you see, it goes without saying that the risk of infection and also complication is very high. So it's only a 1 week vision, and after that it's gone. So right now we get some much improved way to tackle this common problem. This is an old technique called extracapsular cataract extraction, ECCE, long or judgment. What does it mean? It means a big wound, create a big wound, and then you need some suture. And this is the intra-op recording. You need a big wound, and this, you can see this is a cataract, and then we just squeeze the cataract out, as shown here, and then you suture it. All right, and then remove the cortical matter. And right now we've got some newer form of treatment called phaco emulsification, 超聲波預防. All right, you basically use ultrasound to dissolve, all right, to aspirate the lens. All right, you can see we've got a very good improvement in terms of the design of the IOL. Right now the IOL is very small and very tiny. A different type of IOL. So in compared to the ECC or extracapsular cataract extraction, phaco emulsification, the wound is much smaller and got less astigmatism. Okay, but for some patients after cataract surgery, I also got this a lot. All right, every clinic the patient asks, will cataract regrow? The answer is no, cataract will not regrow. But somehow, if after cataract surgery, the patient develops the condition like we call it PCO, posterior capsule opacity, or this could lead to a further drop of the vision. If you have got this, the simple way to do it is to do a laser and then create a hole there over the posterior capsule, and this could create a visual axis to improve the vision. So in comparison, from the development of the cataract surgery, we now know that we are moving towards needleless. We don't need any more needle. Just use some topical anesthetic gel can solve the problem. All right, you don't need needle. You don't need suture. It's because of phaco, very small one, only 2 millimeter, and a foldable IOL. It's very small also. So at the same time, we can correct the astigmatism of the patient during the surgery. So I prepared a video to show to you what we mean by phaco emulsification. Anyone have got trouble of seeing someone picking the eye, or I'm afraid you may faint, but it should be all right. Okay, it's pretty brothers. All right. This is the procedure we call it AK, or accurate keratectomy. We basically create some cut over the junction between the iris and the sclera, and this could solve the problem of astigmatism. And then we create a wound, and this is the main wound. I already inject some material called basically elastic to give room for us. And this is an important step. We will use a forceps to create a break over the anterior capsule. and then we create a, you know, a roundish defect called capsulotomy, capsule over the anterior capsule. And then we use water to mobilize the lens. We call it hydrodissection. So this is the phaco pump, phaco machine. And you will deliver some ultrasound energy over the mobilized lens, as shown here. And then we aspirate. Further aspiration. Okay, we'll create up the residual cell over the capsule. And here, this is the foldable lens, as shown here, successfully implanted into the eye. This is the final readjustment of the position of the IOL. We will remove the viscoelastic material after the surgery, or at the end of surgery, just right before the end. And then we'll fix the wound with some water, we call stromal hydration. We don't need any more suture. Alright, so it's very simple and easy. So I've talked about laser to tackle cataract. Alright, in recent 1 year, there was a trend of people talking about this new technique called laser refractive cataract surgery, or femtosecond laser cataract surgery, 飛秒激光白內障切除. Okay, what does it mean? It means that if you remember, I talked about capsulotomy, right? You use a forceps to create a roundish defect or hole over the anterior capsule. But for this, you use a machine with a laser. You create a very roundish and measured and controlled capsulotomy. And then use a laser to create some cut over the lens, just like cutting a cheesecake, right? And then after this, you open the wound and then aspirate the thing and then insert the IOL. Alright, this might be the future for cataract surgery. Okay, so we know that there's pretty much new advances in cataract surgery right now. So we are primarily very machine dependent. So we are working towards automation and standardization with the hope that we can have a lower risk and more control and predictable visual outcomes for someone who are desperately in need of cataract surgery. Thank you so much for your attention.
多謝劉醫生精彩嘅演講，令到我哋對呢啲常見嘅眼科疾病有啲深刻啲嘅認識。有冇咩問題啊？問下劉醫生。剛才你提到嗰個 macular degeneration 有啲係 antioxidant 或者係 vitamin， 可唔可以講 specific 邊一類嘅 antioxidant 或者 vitamin 係特別會有啲？
好啊，佢咁樣嘅，我識講廣東話嘅其實，咁咧就根據嗰個美國個 AVS study 咧，其實就有一隻市面上都可以講名嘅嘛，叫 iCaps 咁樣。咁佢其實佢個 formula 咧就係即係 vitamin C 啦、vitamin E 啦，有啲叫 beta carotene 胡蘿蔔素啦，同埋鋅一啲混合物。咁佢就俾咗1000幾人食咗10年，咁就觀察到咧佢。如果係有食藥嗰啲咧，佢嗰個由個乾性變成濕性嘅機會咧，係會減咗20%。即係你唔食藥嗰啲咧，就會有個機會，比較起上嚟就會大啲機會，相對大啲機會有濕性。咁但係個問題咧就呢個俾呢隻藥咧，就有時俾病人咧就佢會有個混淆嘅。通常佢混淆咧就話佢醫生點解我食咗咁耐藥都視力都唔好嘅咧？咁其實咧個重點咧就係其實呢個藥咧就唔係愛嚟視力好嘅，佢係愛嚟咧保平安嘅，即係等佢冇事，即係另外一隻眼其實另外一隻眼就唔會出現問題。所以食呢隻藥咧最低嚟個 outcome 咧就係佢乜事都冇。
有冇其他問題？
啲NDVGF 嘅化學藥啦，例如 哋嗰啲可能可以用即係叫做眼藥水嘅方法整下㗎嘛。有冇即係一啲研究證明佢嘅療效可唔可以代替即係 antibody 咧？
嗱，呢個問題好好嘅，但係你留意下，其實佢眼咧係一個密封嘅系統嚟嘅。咁咧變咗佢你要經過咧咁多個 membrane， 即係其實佢有啲好 solid 嘅 structure、sclera 啊各樣嘅嘢，你要再吸收到入去裏邊咧，其實係好少嘅。即係如果你醫腦連環斑退化嗰樣嘢係眼入邊好深藏嘅地方咧，如果你滴嗰條藥水咧，就可能個情況就係一係咧就完全冇效，一係咧就可能有效，但可能要滴幾十年咁先有效咯。咁變咗佢其實個病都已經差咗，所以變咗佢呢個方法咧係有用嘅，但係呢一啲叫做即係嗰個前房 anterior chamber 裏邊，譬如 iris 有啲 neovascularization 嗰啲情況，或者係甚至乎 corneal 有 neovascularization 嘅情況之下咧，咁你咁樣滴咧就可能有效。但係如果係腦連環斑退化，似乎而家就未有一隻好好嘅藥咧，可以有咁高嘅穿透力。
特別嘅職業上嘅關係，即係嗰啲
你呢個問題都問得好好。其實咧就我哋個觀察咧睇病其實係可能係有關嘅，即係我哋其實就唔係同老年有關，因為我哋咧就我哋都會頭先講過啦，即係你嗰個脈絡膜血管增生期 CMV 其實係除咗老年之外，你都可以深近視啊，可以其他發炎啊引起嘅。但我哋發覺到咧有一類嘅職業嘅人咧係會多呢啲嘢嘅，嗰啲咧就係空中服務員，即係啲空姐啊或者係機師啊呢度有。咁個原因咧就有啲人咧有個表就可能佢哋飛嘅時間咧，佢哋比較近個 cosmic ray。即係我唔知係咪啦，因為冇啲 study 去 prove 咗呢樣嘢。但我哋自己嘅 observation 都係呢類人士個 observation 係有時係會有咁嘅情況，唔係好多，但係即係注意到有咁樣嘅。氣壓當然係有可能啦，當然都有可能，即係佢有啲成咁樣。咁但係咧就即係最弊呢啲咁樣嘅嘢咧就好難去分別啦，所以我哋都係冇辦法一個好 confirmative 嘅答案。
除咗氣壓，另外就係你飛到去3萬公尺，就算佢機艙壓縮咗，你個氧氣都係得15%，地面有21%，可能都有啲 hypoxia。
都係嘅，都可能係嘅，有 relative hypoxia。
想問咧嗰個白內障有冇顯化出世？
白內障有明顯化出世。咁就我諗同即係嗰個環境改變有關，因為環境改變咧，佢令到嗰個其實個 UV 啦 ，UV 係其中一個好大 contribution 會令到有 cataract。咁而家日照好犀利啦，你而家香港基本上冇冬天，即係其實曬得好緊要。咁但係啲人似乎有啲人佢哋嗰個對於嗰個防 UV 個 awareness 就唔係話好高嘅，即係都係求求其其咁樣都出去曬下咁樣，咁變咗咁咪會有時曬一曬咪曬一病出嚟咯。呢個問題真係好難答。如果你咁樣 ban 咗，就好多人都冇電話用。我諗咁嘅，我估你擔心佢會輻射，你不如擔心另外一樣好過。如果細路仔，因為細路仔有啲研究咧就話，如果細路咧就喺某一個最 vulnerable 嘅 period 咧，如果你就係俾一啲好近，成日要佢做啲好近嘅嘢。譬如話你好細，可能啲家長有時會攞啲 flash card 俾佢睇啊，嘅教佢認個字啊，又逼佢做好多功課。有澳洲同埋英國咧做過一個好大型嘅即係 epidemiology 嗰啲 study。佢研究嗰就話有啲族群咧就有啲家長咧就會進行一啲即係強迫個細路咧係睇好多近嘢嘅行為，即係行為嗰啲會怪獸家長。咁另外咧有啲咧就係唔係嘅，即係俾佢出邊跑可能係啲大陸山區嘅細路咧，佢發覺佢哋嗰個即係近視嗰個比率咧，其實山區嗰啲人咧係少好多，但係佢哋嘅 gene 係差唔多。 咁佢有一個 theory 就係咁樣，因為你睇近嘢嗰時候咧，其實你不斷 yield 咧，其實你眼球入邊有個肌肉叫節奏體肌肉 cerebral muscle， 咁佢會不斷地會收縮，咁呢個收縮咧會有一個 loop 咧 feedback 去個腦度，咁個腦咧就會分泌一啲叫做神經生長因子，又係啲 CNTF 嗰啲，咁呢個咧就會令到喺細路尤其2到4歲嗰時候咧，就會令到佢嘅眼球咧原本係正常 size 係長咗好多。長咗好多咧，就個直接效果咧就令到佢個近視咧深咗好多。即係原本可能佢係好正常 size， 可能係即係可能係中碼，但係變咗 XXXL 咁樣。咁個原因咧就係因為你咁樣做咧，佢係人一個佢有 theory 就人一個保護嘅人個 auto regulation。你成日俾佢咁細個睇咁近嘅嘢咧，佢可能佢即係佢有一個錯覺個腦，以為佢呢一生人咁樣睇嘅嘢，佢哋真係咁嘅。咁所以咪將眼球拉上去，即係方便佢以後睇嘢。所以就點解有啲都係即係個千係差唔多，點解有啲人咧佢會個近視咁深？譬如10歲同1000度近視，就係咁解。
多謝你，我想問個問題就係話咧，越後生嘅大框咧，係咪同青光眼有關？同埋咧戴乜隱形眼鏡，同埋咧係咪有青光眼或者眼內壓上升唔戴得框？
我諗咁嘅，你如果知道青光眼係乜嘢啦，首先青光眼就唔係你見到青光就叫青光眼啦，呢個唔好誤會先。咁青光眼咧其實係一個視神經嘅一個病變嘅，咁最主要咧都係嗰個眼球，即係最其中一個特點就係眼球壓力係高嘅。咁亦都可以有啲叫正常眼嘅青光眼都可以。咁但係咧，其實佢所有嘢都發生喺眼球入邊嘅。咁但係你戴隱形眼鏡呢個行為係出邊嘅嘢嚟嘅，係咪？即係好快你可以戴到嘅。咁所以咧，其實你喺即係等於你個問題轉化成為你會唔會話戴眼鏡而影響有青光眼？咁你咁樣諗其實唔會嘅。即係眼鏡同隱形眼鏡嘅分別就係隱形眼鏡係冇咗個框，係黐咗喺眼球上邊，但係佢唔係喺眼球入邊。所以變咗你我諗你就唔需要呢個擔心，即係佢反而係戴隱形眼鏡，可能驚其他譬如污糟啊，會唔會有啲角膜潰瘍啊？有時戴得太耐，超過8個鐘，會唔會有啲即係角膜嘅血管增生啊嗰啲問題？就應該同青光眼就冇關係。
就喺啲白內障方面咧，就係遺傳基因嘅係影響重要嘅。
遺傳基因影響重要嘅，咁但係即係佢白內障都係一個 multifactorial 嘅 disease 嚟，但係我哋知道，咁佢係好多pathway 都可以令佢有白內障。咁有啲疾病真係，譬如話佢父母有嘅，個細路就實有㗎啦。不過睇下幾時出係有咁樣嘅白內障，但係亦都有一啲咧係佢有啲行為，佢即係佢喺胎兒喺個母體嗰陣時候，譬如媽媽有個發燒啊，其他感染都可能令到佢有白內障。咁但係亦都係有啲咧係因為佢進行咗某一啲嘢，做咗某一啲嘢，譬如話佢有滴咗某啲藥水啦，咁令佢係有個白內障產生。所以個 gene 嗰度咧係有，但係佢唔係個 one to one， 即係其他 disease 咁嘅 one to one 嘅關係。
我哋好多謝啊劉醫生精神唔到。
好，唔該晒劉副教授。之後到我哋有請實踐大學董事長謝萬雄教授為我哋致送紀念品俾劉副教授嘅，有請。